Thank you so much, sir, for the great info and information and for sharing with us. Now, I would like to call upon the stage Dr. Manish, sir. Dr. Manish, sir, is a founder and director of Metabolic Hospital Research Center, Ahmedabad.
Good afternoon. First of all, thanks to the CardioCon organizer, my good friend of the Dr. Ashutosh Misra and Pallavi Misra, giving the opportunity to this particular CKM. And by 10 to 15 minutes, I'm going to talk of the cardiovascular kidney metabolic health is a accessible vision for the heart failure prevention. How to carry out the prevention of the primordial, primary, secondary, and tertiary care of this particular. These are review articles on the in October 2023. Cardiovascular kidney metabolic health is a presidential advisor from the American Heart Association. You can see of this particular, and we are seeing of the last 1.5 days of the CKM. CKM is just like already earlier speaker is an elephant in the particular rooms. So heart disease, chronic kidney disease, and diabetic and obesity is an interactive risk factor of the CVD. Historical treat the individual often after the condition has progressed in the full round of the fragment. Each condition carries the mortality, morbidity, risk, and multiple conditions, and significant with the multiple risk. You can see of the India is the capital of diabetes. We are having the more than 140 million of the diabetic. And what of type 2 diabetes with CKD act as the risk of the CV compliance. Out of 3, 2 worry or 2 worry, he is a patient is a CV risk. And they are, what about the type 2 diabetes with CKD, and what about the output of the CV death is a 3 times more compared with the alone with the type 2 diabetes. If the eGFR of the stage 3A, they are more prone to the CV death 2 times. If the eGFR stage 3B, you can see of the 2 times and 4 times, you can compare with the ones who are getting the eGFR stage 3A to stage 3B, and chance of the CV mortality, heart failure. What about the cardiovascular mortality are 2 times more common this particular. These are CKM definitions. Cardio-diabetic metabolism is a systemic disorder characterized by the pathophysiology interaction among the metabolic risk factors, CKD, cardiovascular risk, leading to the multi-organs dysfunction because of the high rate of the adverse cardiovascular outcome. Define of the overlap of this particular obesity, pre-diabetic, diabetic with the chronic kidney disease, heart disease, there is a significant interactive for the overall reduction in survival. How to make of that? Grade 3 obesity, BMI is more than 40, 45, median survival is usually 8 to 10 years of the, you can see of this particular male and women with the type 2 diabetes is if the BMI grade 3 and what about grade 3 obesity, lifespan is getting the decrease of the 30 to 14 years. Those on the stage 4 CKD, eGFR is a 50 to 20, 15 and less than 30, 20 years short life expect with the death resulting from the CVD because the measure of the competitive risk factor of developing of the kidney failure, and that they are required the kidney transplant therapy and preventive progress to the disorder to the life. Whatever staging of this particular, currently I am not going to cop the already last 1.5 day we are going to this particular staging of the relation of the how to can prevent access during the early stage of the CKM when they of the most of the early stage of the they are asymptomatically and prevent the premature mortality and mortality. These are very common of the slide of the stage 0, stage 1, 2, 3, 4. How to make of this for the primordial, primary, secondary, and tertiary of the rationale of the staging of the reflect of the pathophysiology of the underlying CKM progress, important of the early detection, under recognize of the clinical condition, each stage to the represent the high level of the absolute risk factor and principal focus on the cardiovascular who are going to ultimately cardiovascular going and primary cause of the premature mortality in the relation with this particular the CKM with the CVD, additional focus of the kidney failure, each stage of the represent the opportunity to the preventive aspect and goal of this particular. I am going to talk with the stage 2, there is no CKM syndrome, but primordial prevention can be prevented. What about this particular? The stage 2 is excess and dysfunction adiposity. Already earlier speaker we have discussed we are thin fat Indian, we are having the more in particular sarcopenia and we are more in visceral fat and rather than the subcutaneous fat, and abdominal obesity and thin arms are this particular, they are more prone to the cardiovascular, and they are good. So adiposity is a root of the most of the metabolic risk factor of the CKD is a under of the stress. Several processes involve the development of the dysfunction of adipose tissue, and stage 1 is a considered impaired glucose intolerance. What about and history of the gestation diabetes? Ultimately, every yearly 25 of the who are having the gestation diabetes, if we are not intervening the lifestyle modification, they are going to develop to the type 2 diabetes of the stage 2 of the metabolic of the multiple risk factor is CKD. Presence of metabolic risk factors, CKD, type 2 diabetes with the CKD, hypertension with the lipid disorder, and consider with the pathophysiology interact of the stage 3. Stage 3 is a subclinical. I am going to already we have discussed of the stage 0, 1, 2, 3, 4 of the 4 stages, full phase of the CKM with the clinical heart disease with the CVD with excess dysfunction of the adipose tissue with the metabolic risk factor with the CKD. Stage 4 and stage 4 is also going to the divide into stage 4A and B. Stage 4 is no kidney failure, and stage 4B is a kidney failure is present, and management of the CVD influenced by the other CKM syndrome. These are stages of cardiovascular of the metabolic. Now, how to make of this of the CKM is going to the health behavior and heart failure prevention. Primordial prevention is a lifestyle, less eating, more fiber, more proteins, less the simple carbohydrate. Some of the trials are going to detailing of the dietary. Already we have discussed the couple of the dietitians of this particular. The Indians is a carb-loving country. Stars are showing most of northeast, southwest. Our 65 to 70% we are taking the carb rather than the proteins. Minimize the prepare the high processed food. Enhance the because of heart failure, saturated fat or should not be less than not more than 7% sodium intake. Indian we are taking more of the processed food. Average Indian and typical Asian genetically we are taking the salt or 7 to 8 grams per day, and according to all the guidelines we should take of the salt of the 1.6 to 2.2 gram per day of the Mediterranean diet. These are some of the dietary. Physical activity is a must of the 150 minutes per week with a moderate intense with the aerobic exercise, and 5 days in week is a exercise of the moderate intense aerobic exercise. Reduction of the heart failure when we are restricted to the 1 to 2 day per week, and among less individuals it will minimize the of the sedentary life and heart failure of this particular. Smoking and tobacco is going to the aggravator or the risk factor of the CKM. Who are smoke, and we can make of the plan of the quiet the smoke, and nicotine, any cannabis, alcohol, good sleep, at least minimum 7 to 8 hours of the sleeping pattern should be good. Management of stress of this particular by the yoga and meditation, then we can make of the precipitate of the there is a placebo control with the outcome clinical trial, how to treatment of the incidence of the heart failure in population who are having CKM 1, 2, 3, 4 stage of this particular. So these are some of the trials name of the losartan with the other trial of the IDNT trials. You can see of the enrollment periods and key eligible and key result. Ultimately, they found of the 1/3 of the heart failure can be reduction once we are going to add with the renin angiotensin inhibitor enzymes of the other with the SGLT inhibitor is a very fantastic molecule. It is prevent the heart failure. It is one of the great 4 pillars. One of the pillars to prevent the heart failure with the AMPA, with the KENA, with the DAPA, with DAPA and others of the sort. I am not going to already, we have discussed lot of the previous speaker of the GLP is definitely now the GLP is a dual agonist with the triple agonist. You can see of the lexinide, liraglutide, semaglutide, exenide, duraglutide, and some of the under the pipeline. You can see of this particular the oral and subcutaneous and non-continuous infusion, and they can prevent not only going to SBOC control, obesity, and what about this particular, these are some of the study with the semaglutide, with the 2.4 milligram, with the 1 milligram, with the oral semaglutide, with the some of the study has shown of this particular. And third pillar, we are going to this particular non-steroidal mineralocorticoid receptor antagonists of the phenderoid. These are some of the very fantastic molecule of the to prevent the heart failure, particularly the CKM or the diabetic, pre-diabetic with the some of the kidney failure because it is anti-proteinuria and anti-fibrotic curves, and it is very fantastic of the molecules of the to prevent the heart failure. These guidelines-based screening approach to the cardiovascular, kidney and metabolic condition, I am talking with the asymptomatically adult of the subclinical heart failure. What about the, I am talking with the subclinical heart failure. Risk, we have to calculate with the risk of the, inform the preventive risk of the, some of the risk factor are reversible, some of the risk factor are irreversible of the, we should get the all the pro and pro BNP test, echo should be done, the systolic and diastolic LDL should be, the lipid profile should be done, subclinical ACVD of the, again risk factor, and who are in the ACVD is a very wide, moderate, severe, and we can give the full dose, mild, moderate and severe statin, and the patient is having the AF on the underlying, the coronary artery disease with aortic stenosis with the CKD, early diagnosis is must, and all the diabetic and CKM patient we are getting the urine for ACR of the macroalbumin. Obesity is a very big one, burning issue of this particular early diagnosis, risk stratification, prevention and treatment, age, sex and BMI and waist ratio, what are the waist ratio, what is the waist and waist circumference, waist should be of the in centimeter of the half of the your height, every person, the risk of the type 2 diabetes, early diagnosis we are seeing of the very younger diabetic, of the type 1 diabetes with the metabolic liver of the disease. Goal of the modified risk factors in management of the control with the selective of the cardiovascular of the this particular, already I have discussed with the ACVD, we should keep the blood pressure in target in the tune of the 120 to 80, and the ADA, according to ADA, we should keep the HbA1c is a 7 to 7.5% of blood cholesterol. All the national international guidelines of the very in the diabetic patients, and we should keep the 70. And the multiple risk factor, we can keep the LDL cholesterol 55, and the patient is having the premature and multiple, we should keep the 35 and 15, the calcified AS, AM and CKD. These are some of the, we should estimate criteria of the 120/80, type 2 diabetes, type 1 diabetes. Already I am going to discuss of this particular multi-level opportunity to the heart failure prevention, to the CKM health promotions of the, these are some of the, definitely we have discussed with the various AI tools of this particular graph, the strong government policy of the development of the educate, addressing the obesity is considered as a disease, expand the coverage of the essential preventive health and sustain the nutrition, diet and multiple discipline of this particular. CKM health with the heart failure prevention is a concept of vision for the improvement, because the pre-risk factor with the CKM risk factor with the condition instead of primordial heart failure prevention of the this particular earlier educate and primary heart failure prevention, intense blood pressure and lipid A, B, C, A for HbA1c, B for blood pressure, C for cholesterol, D for drugs to prevent the heart attack, and total establish the heart failure with the guidelines, and cardiovascular, kidney and metabolic disease, obesity and fatty liver of the metabolic associated with the fatty liver, type 1 and type 2 diabetes, SGLT inhibitor with the GLP, and we should keep the HbA1c 7% of the this particular. So my key message of this particular, heart failure prevalence is growing the worldwide. Onset is linked with the step, the increase in the morbidity and mortality with the healthcare resource utilization. In spite of the substantial progress of the development of the disease-modified therapy, these are various of the good molecules of the treatment of the patient with established heart failure, with the less attention has been given to the heart failure prevention. Modern staging system identify the specific group of the individual with the pre-heart failure stage B, may be particular risk of the development of the clinical heart failure stage 3, and sensitive biomarker of the pro-BNP point of care imaging tools is a powerful full risk score, can be robust and accuracy predict the risk of the heart failure, and longitudinal improvement of the timely revascularizations, involvement of the intervention cardiology, the system of the care, and some of the pharmotherapies. The pharmotherapy has been stepwise reductions of the risk of the heart failure after the acute MI of the. In spite of the improvement of the care with the myocardium, with the care of the respiratory persistent global ischemic heart disease remains the important pathway of the heart failure. Heart failure is a frequent but still is under recognitions of the complications of cardiovascular, ASCVD with AF, with the AS, with the chronic kidney disease, obesity, cardiovascular, kidney and metabolic. Already we have discussed early detection and treatment with the systematic prevention and management of the upstream risk factors should be considered, and we can prevent the heart failure and increase our lifespan. Thank you for hearing me.
Thank you, sir.
Thank you.
That was a nice presentation. And so as you said in your key message, for prevention of the CRM syndrome, especially the heart failure component of the syndrome, do you have some suggestions as to, see, it is, as you said, it is very under-recognized. Nobody is looking for heart failure. You are looking for sugar, you are looking for lipids, you are looking for blood pressure, you are looking for weight. Nobody is looking for heart failure. Very difficult to, pre-heart failure, nobody is looking. Even if patient is in mild heart failure or something, very difficult to recognize. So what do you think should be the strategy of the physician?
This is very good questions. Actually, at least I am going to focus with the primordial prevention. Already is the stage 1. We educate, whatever. Whenever actually you are some of the identification of the risk factors of the, some of the risk factors are reversible, some of the risk factors are irreversible. Definitely in the diabetic patient we are keeping the SBOC 7%, blood pressure 120/80, LDL is keeping the 70, 55, 45, 35. And what will we educate? I think we should get the pro-BNP echo should be done of this particular to prevent the early heart failure. Thank you.
Right, sir. Thank you so much for your nice explanation.
Thank you, sir. Thank you.
So we'll go, I think, running short of time. So I think last speaker is there. Thank you, sir.
Thank you so much, sir, for your valuable
Thank you, sir.
insight.